Hello, I hope you're all doing well. We will be focusing on the basics of dermatology today. Let's start with reading the question first. A 42-year-old female school teacher presents with a chief complaint of painful blistering lesions in the mouth and bridge of the nose, which have worsened over the past 2 months.
She reports difficulty eating and speaking due to painful oral erosions and has noticed some new skin blisters that rupture easily, leaving raw areas. Physical examination reveals multiple oral mucosal erosions and skin blisters on the abdomen and arms as well. A skin biopsy shows suprabasal blisters with acantholysis, and direct immunofluorescence microscopy reveals intercellular deposition or IgG in the epidermis in reticular fashion. Serologic tests confirm elevated anti-desmoglein 1 antibodies.
Cellular junctions connecting keratinocytes in which of the following epidermal layers are impacted?
A. Stratum basale. B. Stratum corneum. C. Stratum granulosum. D. Stratum spinosum. E. Stratum lucidum.
It is always best to read the last line first to ground yourself and pay attention to any relevant details since we are aiming to solve a question in the least possible time. Let's take an overview of the histologic aspect of dermatology today. Here is a diagram depicting the layers of the skin. There are two layers, the epidermis and the dermis. Along with the hypodermis, the epidermis has 5 more layers. Moving from the outer to inner layers, we have the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. The 2 layers of the dermis from outer to inner include papillary layer and the reticular layer. The hypodermis is composed of subcutaneous fat. Here you can have a full view of the various features of the skin layers. Images are always useful, especially for those who have a good picture memory. Some of the details related to epidermal layer is important and may show up while testing. Let's start with the stratum corneum first. This is composed of flattened dead keratinocytes filled with keratin. An important condition related to this is ichthyosis vulgaris, in which there is excessive thickening and scaling of the skin, which is due to a pathology of the stratum corneum. Next, we have the stratum lucidum. This is usually found in the palms and soles, that is the thick skin, and is composed of keratinocytes. Hyperkeratosis may be seen in these regions. Stratum granulosum is also composed of keratinocytes with granules of keratohyaline and lamellar bodies. Here, psoriasis is important since it is caused by the accelerated turnover of keratinocytes. Next, we have stratum spinosum, which has spiny-shaped keratinocytes connected by desmosomes. Autoimmune conditions where desmosomes are disrupted takes place at the level of stratum spinosum and is called Pemphigus vulgaris. Stratum basale has columnar stem cells which give rise to keratinocytes and melanocytes. Cancer originating from the basal cell layers is called basal cell carcinoma, and it may also give rise to melanomas. Now let's dive into the concept of cellular junctions. These allow the binding of the adjacent cells together and subsequently serve to protect and preserve cell function. There are 6 main junctions, namely tight junctions, adherens junctions, desmosomes, gap junctions, hemidesmosomes, and integrins. Notice we will be discussing how when each of these is compromised, it can lead to various conditions. Here is a diagram depicting all of the cell junctions and is useful for learning. Let's zoom into the table to begin learning. Starting at the top, we have the tight junctions, which are located in the apical region of the epithelial cells. They are also called connular occludens. These seal the adjacent cells together, preventing leakage of extracellular fluids, and are composed of claudins and occludens. Condition associated with them is the leaky gut syndrome, where these junctions are compromised and may result in the paracellular shift of any fluids. Next up, we have the adherens junctions, also known as belt desmosomes. These are present just below the tight junctions. They provide mechanical attachment between cells via cadherens, contributing to the formation of continuous belt around the cell. These are important in cancer metastasis, as when these are compromised, it can lead to increased cell mobility and spread of the cancer. Next, we have the desmosomes, also called spot desmosomes. These are present at the lateral membrane of the cell. Their function is to anchor the adjacent cells together through intermediate filaments. Autoimmune destruction of desmosomal proteins causes blistering, especially in middle age. This is due to the production of autoantibodies to desmoglein 1 or 3. Then we have gap junctions, also called nexus, which are also present in the lateral membrane of the cell. These allow direct communication between adjacent cells by permitting the passage of ions and small molecules through connexins. Mutations in the connexin genes can affect nerve function and communication, resulting in a condition called Charcot-Marie-Tooth disease, which is very common in diabetics. Hemidesmosomes are found in the basement membrane of the cell and attach epithelial cells to the underlying basement membrane through integrins, contributing to cell matrix adhesion. Autoimmune condition targeting the hemidesmosomes leads to blistering, especially in the elderly, called Bullous Pemphigoid. Then we have integrins, which are also found in the basement membrane of the cell and keep the basolateral membrane intact by binding to collagen, laminin, and fibronectin. Laminin deficiency can affect the integrin function and can lead to various skin and connective tissue disorders. Once again, this is the overview of the junctions. This information is sufficient to help you in the exam. Now, this is a very high yield table and covers everything you need to know about the two pathologies as mentioned earlier. Take your time to memorize the key points and keep revising. We will be seeing these again when we talk about pathology and medicine. So here we have a listing for Pemphigus vulgaris and Bullous pemphigoid. You need to know the differences in the age, the target antigens, the histopathology, the immunofluorescence, the blisters, oral lesions, the presence of Nikolsky's sign, and any clinical features. Now, as for the question, we have a 42-year-old female who presents with blistering lesions in the mouth. She has skin blisters that rupture easily. A skin biopsy showed that these blisters were suprabasal with acantholysis. The immunofluorescence reveals deposition of IgG in a reticular fashion. Serologic tests confirm anti-desmoglein 1 antibodies. Cellular junctions connecting keratinocytes in which of the following epidermal layers are impacted. Irrespective of the clinical condition, we know that anti-desmoglein 1 antibodies are produced against desmosomes. Desmosomes are characteristically found in the stratum spinosum between keratinocytes. Therefore, we can say safely that the answer is D, and this condition is called Pemphigus vulgaris. Feel free to go over the explanations. Here is the key point. Thank you for listening once again. If you have any queries, comments, or suggestions, you can email me at the given address. Don't forget to like the video and hit subscribe.